Okay. My name is Dr. Umar Saeed, and I'm working as a consultant anesthesiologist and interventional pain physician at Fatwangar Medical Complex, Lahore. And today, the main topic is about occipital nerve block, which include greater occipital nerve and lesser occipital nerve landmark guided. But I would like to start my lecture with the headache because all the things connected with the occipital nerve is about headache. So I will give you the review about headache. It's not so much explanatory, but just the overview of the headache. So let me begin. Uh, what is the origin of pain in the head? There can be extracranial headache, and then it can be intracranial headache, extracranial headache, which includes sinus, eye, ear, teeth, EMGs, blood vessels. These all structures can cause headache. So these are included in the extracranial pain, and if there is an intracranial pain, then it can include meninges, dura, or arteries, or a circle of Willis, and all that. So these are the basic knowledge. So I just go swiftly with this. So classification of headache, as we all know, it can be primary headache or it can be secondary headache. In primary headache, if there is no structural metabolic abnormality, or in secondary headache, it can be as due to some structural or metabolic abnormality. So the primary headache include tension headache, migraine cluster headache, or there are many other in that. And extra secondary, which is due to the some structural damage or metabolic abnormality, or then it comes in the extracranial and intracranial, as we discussed in the previous slide. Extracranial, as we discussed in the previous slide, like sinusitis, otitis media, glaucoma, temporomandibular joint dysfunctions, or osteoarthritis of the TMG, or intracranial, that is SAH, vasculitis, desiccation, central vein thrombosis, tumor, abscess, meningitis, and all that. So, whenever patient present with a headache, we should rule out some red flags with that. If there is any kind of red flag, we should have an opinion from neurosurgeon or neurologist rather than to proceed with ourselves. If there is any kind of red flag, beware. So, what are the red flags? If there is a new onset and patient age is more than 50, if there is a fever or history of weight loss, sudden onset, and patient said that it is one of the worst headache of my life. So you should be aware that it can be some space occupying lesion or any abscess formation, or the patient is with the altered state of consciousness. Morning is headaches associated with nausea, vomiting, and if the headache is worsened with Valsalva maneuvers, so you should be aware that it is one of the red flags. Focal neurological deficit, jaw claudication. Jaw claudication include, and the patient present like when I start chewing, I feel pain or my jaw become tired. Patient will present like that. History of trauma, cancer, HIV. So these are all red flags. You should be aware. So what are the types of headache? It can be many types, but patient just come with the different presentations. But these are 11, 12 general types of headaches. There are cluster headaches, migraine, tension type headache, sinusitis, hypnic, medication overuse headache, caffeine related headache, hangover headache, traumatic headache, menstrual headache, cervicogenic headache, hypertension, TMJ joint dysfunction due to facial pain in origin, or PDPH, या postdural puncture headache. So these are, and all of them have some different distinguished features for which you can judge them that this is what kind of headache. Like if you see a cluster headache, patient will present with a unilateral headache, and patient start feeling complaining that I have a pain behind my eye, or I have a unilateral headache, or there is a lacrimation from the eye. Migraine, you all know, it is also a unilateral headache associated with nausea, vomiting, tension type headache. Uh, Patient will start feeling that I have a tight band around my head. Sinus, it will start complaining that I have a pain around the nose bridge, or under the eye. Hypnic headache. Hypnic headache is something maybe many of you won't heard of it before. The hypnic headache is a rare condition which is included in more than people with the 50 years of age. And you also have to take care of the red flags because it is more than 50. So patient will start feeling complaining that I have a headache, specifically when I'm sleeping, and I wake up with the pain, and it remains for about 3 to 4 hours, and there is no actual, pathology behind that, and the patient will wake up. It is due to some medicational overdose, or it is just due to some tension type headache, but this is specifically patient will complain that I wake up while sleeping, and it is not that harmless. It is not that harmful. It is harmless condition, and you can treat it with some sort of painkillers uh, NSAIDs or something like that. So there are other caffeine-related headache, hangover headache. All we know hangover headache, like those for those people who consume alcohol a lot and next day morning they start feeling pain. Traumatic headache, menstrual headache. A female patient came to you that they have pain in their specific days or menstrual days. Cervicogenic headache. This is something you should all know that every unilateral headache is not a migraine. Migraine, everybody should, uh, should know how to differentiate specifically between cluster headache, migraine, and cervicogenic headache. These are three most common type of headache present to our clinical setups. And for cervicogenic headache, we most of the clinicians or other people, other doctors, they just label it as a migraine. I mean, like 40 years old male presented to you in their 40s, and they start feeling that I start having a unilateral pain from last 2 to 3 weeks, and some people label it as migraine because it is a unilateral headache. So always consider a population with more than 40s present to you with a unilateral headache, and they have recent somehow onset 2 months, 3 months, then you should consider cervicogenic headache with that. So there is other type like hypertension. Patients start feeling pain when there is a blood pressure rise up, or TMJ joint, temporomandibular joint osteoarthritis. Uh, they will start feeling pain in the head. Facial origin pain, like Dr. Saira just explained about the trigeminal, or there is some wrong with the ganglions. So a patient will start feeling pain of the facial pain, and it can present in the head. And the other important type, as an anesthetist, we should encounter the posterior puncture headache. So, and Madam Saira also explained about it somehow. So the next, this is just a slide that a different presentation. The red spot in the red shade in the pictures shows how it presents and what kind of area it involves. Like tension headache, I told you before that patient will start complaining that I have a band around my head. So the area is like this. In migraine, the area is unilateral headache, including eye and somehow the face, and sinus headache around the nasal bridge and upper side of the eye and lower side of the eye. Cluster headache. There is a one very specific test for cluster headache that if you start giving 100% oxygen to the patient will start feeling better. So this is how you differentiate between cluster headache and migraine and other types of headache. EMJ joint dysfunction will patients start feeling pain around the jaw and somehow in the head. And then there is a cervicogenic pain. Patient will start feeling complaining that backside of head or upper side of the head, there is a pain, and in the neck also. There is a hormonal changes like we discussed before about the menstrual cycle pain, or there is a stress pain. So these are the graphical presentation of different kind of patient will present. As we discussed before, that every unilateral headache is not a migraine. So you should know how to differentiate between cluster headache, migraine, cervicogenic headache, and other different type of headache. So let's begin with the core topic, that what are the occipital nerves? Occipital nerves are crucial for sensory perception in the scalp and neck, and their irritation can lead to condition like occipital neuralgia. So in this slide, we have different kind of picture which shows about the capitis muscles. These are the capitis muscles, and these are around the neck, and the occipital nerves run under or in between them. So we have the some main muscles like sinus capitis muscles, and the upside of the. If you see my cursor, this is occipital protrusions. This is the main point for the block you should encounter, that this is occipital protrusions, and there is two nerves running around it, right-sided occipital nerves and left-sided occipital nerves, and then we differentiate into greater occipital and then lesser occipital. So these are the important structures. Uh, Next, we will discuss about the anatomy of the occipital nerves. The occipital nerves consist of three main nerves that originate from the cervical spine nerves C2 and C3. So the first one is greater occipital nerve. It is the largest of the three and provides sensory innervation to the scalp and often involved in headache. So the main nerve which is the cause of headache is or greater occipital nerve, and then it is just lateral to the occipital protrusions. So then there is a lesser occipital nerve that is also, and then it is again on the lateral side of the greater occipital nerve. Just like, just like if I go to show you in the next slide or previous slide, I will explain you later on again. And then there is a third occipital nerve that is also a primary carrier sensory fiber and provides some motor and innervation to the neck muscles also. So if you have having a pain with the head, and then there is also a pain with the neck, so that there can be a two causes. Uh, it can be cervicogenic headache, or it is due to the it can be an it can be a occipital neuralgia, and then it can be third occipital nerve involved. These nerves are responsible for transmitting sensory information to the scalp, to the brain, playing the vital role in pain perception and sensation in the posterior and lateral scalp regions. So this is the and there are many. It have a detailed anatomy. It have capitis muscles, lenis capitis, and then there is a occipital protrusions in the middle. And there is two nerves run along it. These are third occipital nerve. It lies a little bit deeper, and the on the surface side we have this is greater occipital nerve, which is just medial to the occipital artery. So you have to take care about the block. If you are blocking the greater occipital nerve, you should consider that there is an artery running lateral to it. So you should be careful about that. So we just use the different abbreviations for that. You have to remember three mnemonics like gone, lon, and ton. Gone is greater occipital nerve, lon is lesser occipital nerve, and then ton is a third occipital nerve. So gone, as we discussed, is the biggest and purely efferent nerve. Acha, in this lecture, we are discussing about the nerve blocks. So everybody should have a knowledge about what is afferent, what is efferent, what are the motor nerves, what are the sensory nerves. So you have to differentiate about that. So the gone is a biggest of all, and it is just a efferent nerve, which is a sensory nerve, which means it is a sensory nerve, and it runs from the dorsal ramus of C2. Just like the lesser occipital nerve is also it originates from the ventral rami of the C2. So the gone is more sensory than the lesser occipital. And then there comes a third occipital nerve, which is also which arises from the third spinal nerve. So, what is occipital neuralgia? Occipital neuralgia is a condition characterized by irritation or inflammation of the occipital nerves, leading to severe, sharp, and throbbing pain in the back of the head, neck, and behind the eye. People can confuse it with migraine or other type of headache because the symptoms are very similar, but the treatment for those conditions are very different. So, it is important to see your doctor to get the right diagnosis. So here is a concept that how it is differentiate from the migraine. Occipital neuralgia is purely nerve in origin. It have a neurogenic or neuropathic conditions like burning, aching, throbbing pain, sharp shooting pain. These are the characteristic of pain with the neurogenic origin. And there are some somatic pains which have different. Those are dull pain, somehow continuous pain. So, you should differentiate between the neuropathic pain and the somatic pain and what kind of fibers it carries. Like it is a like A fiber or C fibers. We should differentiate about them. Then there is a symptoms of occipital neuralgia. There is a aching, burning, and throbbing pain that typically starts at the base of the head and goes to the scalp. It starts from your back of the head and then it comes to the scalp. Pain in one or both side of the head, because sometimes only one unilateral occipital nerve is involved, or sometimes it can be bilateral. So pain behind the ears, sensitivity to the light. So you can see this is also a common condition like migraine, sensitivity to the light. But in occipital neuralgia, you have a tenderness around occipital areas, and then you have a tender scalp. In migraine, you will not have a tender scalp. Pain when you move your neck, yeah, the range of the motion is disturbed. Numbness. This is also a characteristic of neuropathic pain, and the pain is behind your ears. Causes of occipital neuralgia, or what kind of condition it can be linked to: trauma to the back of the head, neck tension or tight neck muscles, osteoarthritis of the cervical spine, tumor of the neck, cervical disc diseases, and then there can be infection, gout, diabetes, blood vessel inflammation. It all causes occipital neuralgia. And then there comes the occipital blocks. How we block the occipital nerves and what kind of setup we need, what kind of condition it addresses. Occipital nerve block can be for the headache, neck pain, postdural puncture headache, and specifically for occipital neuralgia. And there can be other associated with that. Occipital nerve block is a procedure where the healthcare provider inject a combination of anesthetic and sometimes steroid medicine. So there is a difference between the therapeutic block and diagnostic block. So if you just want to have a diagnosis to confirm your a diagnosis of occipital neuralgia, you just give local anesthetic. But if you want to give a therapeutic block, then you just add on steroid with that so that the block will be prolonged. This is a primarily done to relieve pain associated with the irritation of occipital nerve, which can lead to the chronic headache. Aims to disrupt pain signal and elevated discomfort in the affected region. Occipital nerve block are a type of therapeutic pain procedures that include injecting a local anesthetic in the area around the occipital nerve. The occipital nerve is a branch of C2 and C3 nerve roots exiting the spinal cord and extended up to the back of the head toward the top of the head. So, if you have all the symptoms like neck pain, occipital tenderness, scalp tenderness, the block will cover all that. So, as we discussed before, these are the conditions for which you can give the occipital nerve block. So, what is the procedural overview? As like other blocks, there is a preparation for that. You should have a consent with the patient. You should explain the patient that how we going to perform this block. There can be a few injections with that, like local anesthetic or with the steroid, and then there is a monitoring during the procedure and after the procedure. So this is the overview of the block, how we are going to perform it. And it is just typically a outpatient setting. There's no need to, you don't need to admit the patient. It is a day procedure allowing patient to return home shortly after or after the injections. The patient is usually you can give the block in the sitting position or you can give the block in the prone position. That's totally up to you. If you feel that patient is with the small heart and it can be fall down, so you should not try in the sitting position. Sometime the patient feels start feeling uncomfortable, or sometimes it get even have a syncope episodes. So you should try to avoid that and just give the in the prone position, lie down. The health provider provides identify the precise injection site and the bony ridge at the back of the head, which is occipital protuberance. And then you can give it with the help of image guided or fluoroscopy guided or landmark guided. Landmark guided is as good as fluoroscopy or ultrasound guided. Even though if you say that those are more safe than landmark guided, but efficacy is equal. So the effectiveness and duration of the block. The effectiveness of the occipital nerve block can vary among the individual. Many patients experience significant pain relief, which can last from few days to several weeks. In some cases, the procedure may need to repeat for continuous relief. When generally safe, potential risks include infections, injection site, bleeding, bruises, temporary numbness or weakness in the area. Uh, when you give the block to the patient, patient will immediately said that I have a pain relief, but my head is numb. I start feeling numb in the scalp area. So you should explain this to the patient. So let's come how we perform it. These are the important structures we should consider before giving the block to the patient. That if you look at the back of the head and you if you just even now if you are sitting and listening to the lecture, just put your hand at your back of the head, and you will start feeling that there is a protuberance just above the neck. If you see my cursor, this is occipital protuberance. Okay, and then there is a nerves lateral to that. If you want to map it, you can map it. And the problem with the occipital nerve landmark guided occipital nerve block, because all the patients have hair on their head, so it is difficult to mark it. But it's not that difficult to just go with that. So if you draw a straight line at your back, there is a protuberance just uh, downside of your neck. That is a C7 spinous process, and you just go above to the that, and when your head freeze start, there is a occipital protuberance. So this is the injection site for the greater occipital nerve. We, uh, I will discuss it one by one. First, we will discuss about the occipital greater occipital nerve block, and then there is a lesser occipital nerve block. So at the back of the head, there is occipital protuberance, and if you just inject approximately 1.5 centimeter lateral, just from the occipital protuberance, you will draw a line from occipital protuberance to mastoid process. There is a straight line, and you just divide this line into three parts: one, two, and three, or you can make it like one, two, three, four. So the second part is greater occipital, which is exactly or approximately around 1.5 centimeter lateral and 3 centimeter below. So this is the point where you have to inject your local anesthetic or local anesthetic with steroid for the therapeutic block. So let's come with the next slide, which is also about this the same procedure, that occipital protuberance, and then you just 1.5 centimeter lateral and 3 centimeter down. So this is our occipital. There is a point for the uh, greater occipital. So this is one of the slides. If you see, there is when you give the occipital nerve block, the block will affect in this way the red shade. It will cover an area like this. The numbness of the block will be in this area. The target of the injection of the greater occipital is one-third of the midline. Again, I am repeating it, on the line between the occipital protuberance and the mastoid process. The red area is the region that is usually numb with the greater occipital nerve. And then there comes a lesser occipital nerve block. For the lesser occipital nerve block, you just extend your line towards the mastoid process, and in the second half, you will. It is just like as we discussed before, first half, second half. So in the second half, there is a lesser occipital nerve. The target of the injection of the lesser occipital nerve is two-thirds of the midline between the occipital protuberance and the mastoid process. For a one-third, and then there is a two-third. One-third is the greater occipital, and two-third is the lesser occipital. So the red shadow is the area which is numb after the lesser occipital. So these are the two targets as we discussed before. Okay. Okay, this is a similarities patient. We just prepare for that. So we will not put the actual needle with the patient because he is my OT assistant. So just we will have a view for that. As you see, my thumb or my finger is at the occipital protuberance, and then we just draw a line from occipital protuberance to the mastoid process here. So these are two lines, and we just divide this line, or we draw a line from here, just like I'm using the tissue paper to just show you how to draw a line. So if we divide this into three parts, one third, and then there is a two third. This is one third, and then this is the two third. So one third is the greater occipital nerve, and then two third is the lesser occipital. And we just hit the needle at the we just hit the bone and just slide down, and then just give the block over there. And we just give in a fan position, just like we just give the rotate the needle from lateral to medial so that the block will be spread around and the nerve should be covered. And in the same, we will do the same for the lesser occipital nerve. We just hit the bone, slide down, and then just give the volume over.
So
And then
slide
just
down
I just
means,
want to show
yes, sir.
I just want to show you with the Siam that how it look like. Just a minute. I'm just putting a needle on the surface so that you can have a view of the occipital protuberance. He's just adjusting the Siam so that you have a clear view. Just a moment, please. I just have my needle at the occipital protuberance. You can see this is the occipital protuberance, and I just have my needle tip at the occipital protuberance.